Welcome back to the Deep Dive. Today, we are undertaking a really critical mission. We're going to peel back the layers on the condition famously known as the silent killer.
That's right.
We're diving deep into hypertension, high blood pressure. It's a condition affecting nearly half of the adults here in the U.S., and it's still the world's leading killer.
It is terrifying, isn't it? Precisely because it is silent. You know, you feel fine, completely normal. But inside, there's this chronic corrosive pressure damaging your entire circulatory system.
Yeah.
And the statistics, they're hard to ignore. That's really why this deep dive is so essential. We're talking over 119 million U.S. adults with high blood pressure.
Wow.
But here's the kicker. Only about 1 in 4, just 1 in 4 of those people actually have their condition under control based on, modern therapeutic standards.
1 in 4.
That failure rate.
It just tells us we need a much, much deeper understanding of this threat. Okay, so for listeners who might need a quick refresher, let's start with the basics. When we get those two numbers, like, say, 120 over 80, what exactly are we measuring?
Right, good question. We're measuring the force exerted by your blood as it pushes against the walls of your arteries. And that pressure, it's measured in millimeters of mercury, or mmHg.
Okay.
So the first number, the higher one, that's the systolic blood pressure, or SBP. Think of it like the peak pressure, right when your heart muscle contracts and pushes the blood out.
Got it. SBP is the action shot, the peak force. So what about that second number, the lower one?
That's the diastolic blood pressure, DDP, the bottom number. And that represents the pressure that's left in your arteries when the heart is relaxed, filling back up with blood between beats.
Right, between beats.
And knowing both is absolutely crucial because the diagnosis and how severe we think it is actually determined by whichever number is higher. Stage 1 could be just the top number being high or just the bottom.
And the definition itself, the goalpost for what counts as high, they've shifted quite a bit in recent years, haven't they? Organizations like the American College of Cardiology, the American Heart Association, they've lowered the threshold. It feels like doctors are treating earlier now.
They absolutely are, and for good reason based on the data. The current clinical definition for hypertension actually begins at 130 over 80 mmHg. So let's maybe walk through the categories quickly just so you can clearly see where your own numbers might fit.
Yeah, good idea. Normal.
Yeah.
That's where we all want to be, obviously.
Exactly. Normal blood pressure is anything less than 120 systolic A&D, less than 80 diastolic. If you're consistently in that range, you're in great shape. Keep it up.
Okay, less than 120 over 80. Then we hit the first sort of warning sign, right? Elevated blood pressure.
Yes, this is a really critical transition zone. Elevated means your systolic pressure, the top number, is between 120 and 129. But, and this is key, your diastolic pressure is still normal, so it's below 80. This is a definite red flag. It signals that immediate lifestyle changes are really needed to prevent it from progressing into full-blown hypertension.
And then stage 1 and stage 2, these are defined by increasing levels of risk, I assume.
Correct. Stage 1 hypertension is when your SBP is between 130 and 139, or your DBP is between 80 and 89. Notice the or either number being in that range counts.
Right.
Then stage 2 hypertension is the most serious category. That's when you're clocking in at 140 systolic or higher, or 90 diastolic or higher.
Okay, 140 or 90, that's stage 2.
Exactly. And it's important to stress, like the ACC does, that a formal diagnosis needs consistent readings. You need at least 2 separate high measurements taken on 2 different occasions, usually in a clinical setting, not just one high reading.
That requirement for multiple measurements, it really points to one of the biggest challenges in diagnosis, doesn't it? Our own stress or anxiety can completely skew the reading, like the classic example, white coat hypertension.
Oh yeah, it's extremely common. White coat hypertension is exactly that. Your blood pressure shoots up in the, let's face it, sometimes stressful healthcare setting. Maybe it reads 130/80 up to, say, 160/100 in the office.
Right.
But then when you measure it quietly at home, maybe relaxing on the couch, it's perfectly normal. Doctors know this happens. They can't just ignore the high readings, but they realize it might just be situational anxiety.
But there's the flip side, too, isn't there? A condition that strikes me as, well, maybe even more dangerous for the individual because it gives this false sense of security.
You're talking about masked hypertension. Yes, that one is definitely insidious. Imagine a patient comes into the office, they're calm, their reading looks great, maybe 125 over 75, seems perfectly normal.
It's good on paper.
Exactly. But outside the office, maybe due to work stress or diet or whatever lifestyle factors, their pressure is actually consistently high. perhaps 135 over 85. Because that in-office reading looks fine, the underlying condition gets missed or masked.
Which is why home monitoring is so important.
Absolutely. Using validated home monitoring devices, or sometimes even 24-hour ambulatory monitoring where you wear a cuff continuously, is often necessary to get the real picture of someone's blood pressure throughout their day.
Okay, so we understand the numbers, the stages, and these diagnostic pitfalls. But to really appreciate why treatment is so urgent, we need to look at why this pressure builds up in the first place. The sources usually divide this into two main types, right? Primary and secondary.
That's right. The vast majority, we're talking over 90% of cases, is what we call primary or sometimes essential hypertension. Now, the label essential sounds a bit academic, maybe even misleading.
Yeah, like it's necessary or something.
Exactly. But really, it just means there's no single identifiable medical cause that we can point to. It's usually a complex mix of factors, genetics playing a role, diet definitely, weight, lifestyle, the environment, all combining to cause the pressure to slowly, gradually ramp up over many years.
So if there's no single smoking gun, what's the actual mechanical failure happening inside the body? What's driving that pressure up systemically?
Yeah, good question. It's really a systemic failure, boiling down to two core problems. There's often too much fluid volume in the system, and there's too much restriction or tightness in the blood vessels.
Okay.
Think of your circulatory system kind of like a plumbing network, right? If you increase the amount of water flowing through the pipes, that's the fluid volume. And at the same time, you narrow the diameter of those pipes, that's the vessel restriction, what happens to the pressure gauge.
It's going to spike. High volume, narrow pipes equals high pressure. Makes sense. So how does the body narrow those pipes?
Well, that's where some complex regulatory systems come into play. In essential hypertension, we often see chronic activation of the sympathetic nervous system, the body's fight or flight response.
Stress response.
Exactly. When that's chronically turned on, even at a low level, it causes this generalized tightening of the blood vessels all over the body. That increases what doctors call the total peripheral resistance. It's harder for the heart to push blood through.
Okay, so tight vessels, what else?
Well, alongside that, there's often an impaired response in a really key system called the renin-angiotensin-aldosterone system, or
Right.
RAAS for short.
RAAS. Okay, that's a mouthful. For the listener trying to grasp the mechanism, how does the RAAS system normally affect blood pressure and what goes wrong?
Right. It sounds complicated, but RAAS is basically the body's master regulator for fluid balance and blood vessel tone. It controls how much water and, crucially, sodium the kidneys hang on to.
Sodium.
Yes. And it also produces hormones like angiotensin II that directly constrict blood vessels. So if this RAA system is impaired or just chronically overactive, which seems to happen in a lot of essential hypertension, it leads to the kidneys holding on to too much salt and water. That increases the total fluid volume.
More water in the pipes.
Exactly. And it also causes inappropriate tightening of the vessels, increasing that resistance again. So it's kind of a double whammy. The heart ends up having to constantly pump against this abnormally high pressure, increasing what we call the afterload. It's just working way too hard all the time.
That explains the primary type really well. So the other, 10% or less of cases is secondary hypertension? That sounds more like a detective story because you actually have to find a specific root cause.
Precisely. Secondary hypertension means the high blood pressure is being caused by a distinct, often treatable underlying condition. A really common example these days is severe obstructive sleep apnea, or OSA.
How does sleep apnea raise blood pressure?
Well, with OSA, you have these repeated episodes during sleep where breathing stops or gets very shallow, your oxygen levels drop, and each time that happens, it jolts your sympathetic nervous system awake, that fight or flight response again.
Oh, okay.
These repeated oxygen drops and sympathetic surges throughout the night cause temporary spikes in blood pressure. But over time, with chronic, untreated OSA, those spikes can lead to the blood pressure becoming chronically elevated even during the day.
And I imagine conditions affecting the body's internal plumbing, like the kidneys, are major culprits too.
Kidneys are absolutely crucial, yes. If you have chronic kidney disease, the kidneys lose their ability to effectively manage salt and fluid balance. The body ends up in a state of chronic volume overload, too much fluid again, and that directly drives up the pressure.
Makes sense.
We also see secondary hypertension caused by things like adrenal gland tumors. Sometimes these tumors produce excess hormones like aldosterone or cortisol, which basically force the body to retain more salt and water, pushing the pressure up. Certain medications can do it too.
Okay, so whether it's primary or secondary, the result is this damaging high pressure. And that label, silent killer, it's really earned because these insidious mechanics, they lead to devastating consequences down the line, often permanent damage. Uncontrolled high blood pressure is like a constant physical assault on the arteries, isn't it?
It really is. It's chronic trauma to the vessel walls. And look at the prognosis. The numbers are stark. The risk of death from stroke or heart disease roughly doubles with just a 20 millimole Hg rise in systolic pressure or even just a 10 millimole Hg rise in diastolic pressure.
Well, yeah.
That excessive force, day in, day out, damages the delicate inner lining of the blood vessels. It accelerates atherosclerosis, hardening of the arteries basically everywhere in the body.
So which organs bear the brunt of this? Which ones are most at risk?
Well, the big targets are the heart, the brain, the kidneys, and the eyes. They all rely on a healthy network of blood vessels.
Let's take the heart first. What happens there?
For the heart, that constant high afterload we mentioned, pumping against resistance, forces the main pumping chamber, the left ventricle, to work harder. Over time, the muscle wall thickens to compensate. This is a condition called left ventricular hypertrophy, or LVH.
Is thicker muscle bad? Sounds stronger.
You'd think so, but it's actually bad news. A thickened heart muscle becomes stiff, less flexible, and ultimately less efficient at pumping blood. LVH is a major risk factor. It's basically the fast track towards developing heart failure, heart attacks, and angina, or chest pain.
Okay, so heart failure, heart attacks. What about the brain? Stroke risk, obviously.
Absolutely. High pressure pounding away in the small arteries of the brain dramatically increases the risk of both types of stroke. Hemorrhagic, where a vessel bursts, and ischemic, where a vessel gets blocked.
Scary stuff.
But even below the threshold that causes a full-blown stroke, chronic hypertension can cause more subtle damage. It can lead to what's called vascular dementia. This means cognitive decline, memory loss, difficulty concentrating or thinking clearly, simply because the small blood vessels supplying the brain tissue are constantly stressed, damaged, and eventually start to fail over time.
Wow. Kidney damage, too, you mentioned.
Yes, the kidneys are basically intricate filters made of tiny blood vessels. High pressure damages these delicate structures, impairing the kidney's ability to filter waste. This can lead to chronic kidney disease and, in severe cases, kidney failure requiring dialysis. And eyes, vision problems, retinopathy.
Right, it really affects the whole system.
Yeah.
And we absolutely have to define the emergency state, the point where it's not just chronic damage, but an immediate crisis.
Yeah.
The hypertensive crisis.
Yes, this is the red alert. A hypertensive crisis is generally defined as when the blood pressure spikes dramatically, past 180 systolic or 120 diastolic.
180 over 120.
Right. If you hit that number, especially if it comes with symptoms suggesting acute organ damage, things like severe chest pain, a crushing headache, sudden vision changes, shortness of breath, confusion film, you need immediate emergency medical attention. It means the body is actively being overwhelmed by the pressure.
Okay, that's the threat picture. Serious stuff. Let's pivot now to the action plan. Because the good news is we do have powerful strategies, really a dual approach to take control of this. And it starts with non-pharmacological management, right? Lifestyle changes. That's the foundation for everyone, even people who end up needing medication.
Absolutely. Lifestyle changes aren't just a suggestion. They need to be lifelong commitments. And probably the single most effective dietary strategy we have evidence for is the DDH diet. That stands for Dietary Approaches to Stop Hypertension.
DHH diet, what does that involve?
It's not some weird fad diet. It emphasizes eating plenty of fruits, vegetables, whole grains, lean protein, low-fat dairy, foods naturally rich in potassium, magnesium, and calcium. These minerals actually help counter the effects of sodium and relax blood vessels, naturally lowering blood pressure.
And speaking of sodium, that seems to be the #1 dietary target for reduction, right?
It is tough, no doubt, because sodium is hidden everywhere in processed foods, but it's paramount. The ideal goal, according to guidelines, is to restrict sodium intake below 1,500 milligrams per day.
1,500 milligrams, it sounds low.
It is low. For context, the average American probably consumes double that, maybe 3,400 milligrams or more. So hitting 1,500 feels difficult, but the sources consistently show the payoff in blood pressure reduction is immense. It's worth the effort.
Okay, diet is key. Beyond that, weight management seems to offer huge returns as well.
Massive returns, really significant. The sources often cite that losing even a modest amount of weight, just 3 to 5% of your total body weight if you're overweight, can lead to a drop of anywhere from 5 to 20 millimilli-G in your systolic pressure. That's comparable to some medications.
Wow, just 3–5%. That's achievable for many people.
It is. And you combine that weight loss with a regular physical activity routine aiming for something like Moderate to vigorous exercise, maybe brisk walking, swimming, cycling for about 40 minutes, 3 or 4 times a week. Now you're implementing really powerful drug-free therapy.
Makes sense. And then there are the things to cut out, the habits that cause those immediate pressure spikes.
Exactly. Quitting smoking is huge. Smoking causes immediate vasoconstriction, tightening of blood vessels, and fires up that sympathetic nervous system we talked about. Quitting provides instant benefits for blood pressure, not to mention everything else.
And alcohol.
Limiting alcohol is also key. The recommendation is generally no more than 1 standard drink per day for women and no more than 2 per day for men. More than that consistently raises blood pressure.
Right. And what about stress? We all have it.
Yeah, stress is tricky because it causes temporary BP increases. While managing chronic stress might not permanently lower baseline BP like diet or exercise, using techniques like mindfulness, meditation, deep breathing exercises, even just taking regular walks can help manage those temporary spikes and improve overall well-being, which indirectly supports blood pressure control.
Okay, so lifestyle is the foundation. But for many people, especially those starting in stage 2 hypertension, or maybe those with other risk factors like diabetes or kidney disease, lifestyle changes alone might stabilize things. But they often still need medication to actually hit that target goal, which is usually 130/80, right?
Absolutely. Pharmacological therapy medication is very often a necessity to achieve optimal control and prevent those long-term complications. Instead of trying to list every single drug name, which would be overwhelming, it's maybe more helpful to group them by how they work, how they fix the plumbing problems we discussed earlier.
Yeah, that would be helpful. What are the main functional groups of blood pressure meds?
Okay, broadly speaking, you have drugs that help relax or dilate the blood vessels. This group includes the ACE inhibitors, you might see names ending in pril, and the angiotensin II receptor blockers, or ARBs, often ending in sartan. Both of these work directly on that overactive RAAS system we mentioned, helping the arteries relax and lowering that peripheral resistance.
Okay, vessel relaxers. What else?
Then you have drugs that work primarily on reducing the fluid volume. The main players here are the diuretics, sometimes called water pills, especially the thiazide type. They basically help the kidneys flush out excess salt and water from the body. Less volume, lower pressure.
Makes sense. Relaxers and volume reducers. Is there a third group?
Yes, there are also drugs that work more directly on the heart itself, slowing down the heart rate or reducing the force of its contractions. This includes beta blockers, often ending in olol, and calcium channel blockers, or CCBs. CCBs actually have a dual effect. They also help relax blood vessels.
Okay, so several different mechanisms. And doctors rarely just use one, right? I hear the term polytherapy a lot.
That's right. For many patients, especially those starting with higher pressures or those with other health conditions, relying on just a single medication, even at a high dose, often isn't enough to reach the target goal. The current consensus strongly supports polytherapy using 2 or more different types of drugs simultaneously, often combined into a single pill for convenience.
Why is using multiple drugs often better than just cranking up the dose of one?
It's generally found to be more effective and often safer or better tolerated. By attacking hypertension using different mechanisms at the same time, say, relaxing the vessels and reducing the fluid volume, you're much more likely to achieve that target blood pressure, that goal of 13/80 or less. This is especially critical for high-risk patients, like those who've already had a heart attack or have diabetes. Plus, using lower doses of 2 drugs might cause fewer side effects than using a very high dose of 1 drug.
That makes sense. But this brings us to what seems like a huge challenge in managing hypertension: adherence, getting people to actually take the medication consistently. If patients feel fine, which they usually do with hypertension, and then they start a drug that maybe causes a minor side effect, like a dry cough from an ACE inhibitor, or maybe some ankle swelling, pedal edema from a CCB, it must be really tempting to just stop taking the pill.
It's the absolute core paradox of managing a silent disease, isn't it? You feel perfectly fine, you start taking medicine, and suddenly maybe you don't feel quite as fine because of a small side effect. The natural human inclination is often to stop the thing that seems to be causing the new problem. But the evidence, the sources, they are crystal clear on this. The long-term damage from untreated or poorly controlled hypertension is exponentially more dangerous, more life-altering, than managing most common medication side effects. Improving adherence is crucial. Patient education is key, understanding why the medication is necessary. And also finding simple, structured routines helps, like tying pill taking to a daily non-negotiable activity, maybe keeping your pills right by your toothbrush. Make it automatic.
Good tip. But even when patients are adherent, we still run into gaps in the healthcare system itself, right? You mentioned earlier that only about 1 in 4 people actually have their condition controlled.
Yeah.
Part of that failure seems to start right at the beginning with screening.
The lack of routine screening is actually quite shocking when you look at the data. One survey mentioned in the sources found that blood pressure was measured in only about 56% of all patient visits across different settings.
Only 56%, that's not great.
Not great at all. It means we're potentially missing the silent killer in all sorts of places where patients are interacting with the healthcare system. Maybe they're seeing specialists, an orthopedist for knee pain, a dermatologist, even a dentist who might not view BP measurement as part of their primary role. So earlier mild cases can just slip through the net, sometimes for years, until major damage starts to occur.
A real missed opportunity for early intervention. And finally, even with good screening and adherence, some cases just prove incredibly difficult to manage, don't they? They refuse to cooperate.
Yes, these are the challenging cases of what we call resistant hypertension. This is formally defined as blood pressure that remains stubbornly high above the goal, despite the patient sticking to lifestyle changes and taking at least 3 different classes of antihypertensive medications at optimal doses, including a diuretic.
3 drugs and it's still high.
Exactly. These patients require a much more intensive, coordinated approach. Often an interprofessional team is needed, maybe a hypertension specialist working closely with a cardiologist, a nephrologist to check kidney function and rule out secondary causes, and a nutritionist for intensive dietary support. They really have to dig deep to figure out why the pressure isn't responding and find a customized drug regimen, sometimes involving older or less common medications.
Okay, this deep dive has really shown us that hypertension isn't just some inconvenient number on a cuff. It's a complex systemic failure that demands ongoing vigilance and usually a combination approach using both lifestyle changes and medication.
Exactly right. So if we boil it down, our 2 crucial takeaways for you, the listener, are actually pretty simple, but vital. First, know your numbers, find out what your blood pressure is, understand where it falls in those categories, and aim for that optimal normal zone below 120/80 millimilli Hg.
Know your numbers. Step 1.
Step 1. And second, if your numbers are elevated or already in the hypertensive range, you have to commit fully. Commit to that necessary combination of lifestyle management, the diet, the activity, and medication adherence if your doctor prescribes it. That commitment is truly the only reliable way to safeguard your long-term heart, brain, and kidney health.
Well said. And to leave you all with one final thought, something I found fascinating in the source material that shows just how dynamic this condition is. It relates to age and which number matters most. Most people, myself included, tend to focus on the top number, the systolic pressure. But it turns out that isn't always the highest risk factor.
That's a really interesting point. The sources do highlight that the relative importance of systolic versus diastolic pressure actually seems to shift across our lifespan. It appears that until about age 50, the diastolic blood pressure, that bottom number, the pressure when the heart is resting, is considered the more potent or stronger predictor of future heart disease risk.
The bottom number matters more when you're younger.
Seems that way. It reflects the constant pressure load on the arteries even during rest. But then once you cross that threshold, around age 50 or so, the focus shifts entirely. The systolic blood pressure, that top number, the peak pressure during the heartbeat, becomes the dominant predictor of cardiovascular risk later in life.
Wow. That's a clear reminder that our body's needs, our risk factors, they aren't static. They're constantly evolving. And our approach to managing something like blood pressure needs to evolve right along with them throughout life.
Food for thought indeed. It's not a one-size-fits-all situation, and it changes over time.
Absolutely. Well, that's all the time we have for today. Until next time, keep digging deeper.